Thank you very much for the nice presentation, very clear and precise. And I don't think I might have much to add, except to say that for parathyroid diseases, we need to be very, very highly suspicious in our environment. One, maybe because we have a lot of sunshine, we may not be having a lot of patients with vitamin D deficiency. You saw in one of the slides that when he showed that sunlight, then which gets onto the skin, and then there's the different steps in the formation of vitamin D. In Africa, we are, especially around the equator, we are glad to have 12 hours of sunshine, 12 hours of darkness. In other areas, especially in the northern and southern hemisphere, that is not the case. They have shorter daytimes, and then exposure to the sunlight becomes like a very big issue, even luxury at one time, because you need at least 1 hour exposure to the sunlight, if not 2, in order to get sufficient amount of vitamin D, which is really important in the absorption of calcium in the GIT, which is the main source of calcium in the body, absorption in the GIT. Now, in those areas, the northern and southern hemisphere, where the daytime is short, vitamin D replacement in food, fortified foods, is very key, because then you reduce the rate of hyperplasia. Actually, in one of the meetings that I went, I saw a number of parathyroid adenomas removed, or hyperplasias removed, because when they become hyperplastic or they form adenomas, then they produce a lot of parathyroid hormone, then causing hyperparathyroidism, and will necessitate removal of the gland. So in our center here, because we have that luxury of plenty of sunshine, we always miss out the hyperparathyroidism or parathyroid diseases because of that. So we have to have high index of suspicion. Somebody comes with a weak bone, a renal stone, or an abdominal calcification you see somewhere, have hyperparathyroidism at the back of your mind. A brown tumor of the bone, have hyperparathyroidism at the back of your mind. And then, if you have urology clinics, always alert the urologist that please ultrasound of the abdomen of the kidneys. If it shows a stone, look at the neck. Or if you are running an orthopedic clinic, any fracture that is unexplained, please look at the neck. Do some parathyroid hormone assay or calcium assay. For all the patients I have got, most of them, a number of them have been missed by our orthopedic team, because they see a fracture, they think it is pathological, or they think it is they ignore, and then perhaps think of fixation, think of bone biopsy. And when the bone, actually, it is even difficult to do a fixation because the bone is thin. The cortex is so thin that if you try to do any fixation, you will just break the whole bone. So they most commonly do a bone biopsy. And then it comes out, especially for either pathological fracture or brown tumor of the bone, they go ahead to do bone biopsy without any suspicious without any suspicion of a parathyroid. So you as the endocrine surgeon gets at the tail end of the diagnosis, which is unfortunate. So what I'm saying, have high index of suspicion. Anybody coming with calcification where you don't understand why they should have it, bone pains, muscle aches, check his or her parathyroid gland, do an ultrasound of the neck, do serum calcium. I know PTH is much more expensive to do, but in the end, when you find a high calcium level, a low phosphate level, do parathyroid hormone assay. It's around about, commonly it is around 150,000, a little expensive for the common person. Then two, when you have done your parathyroidectomy, always follow up the patient. If this patient calls you, because most times we discharge our patients postoperatively after maybe a day, because we don't usually keep our thyroid patients long. If this patient goes home, especially when you start dealing with private patients, and the patient calls you that, oh, doctor, I am feeling muscle aches. I'm feeling my whole body is painful. Don't ignore. Don't say perhaps because of muscle relaxant, because muscle relaxants have that effect. That fasciculation that muscle relaxants cause during induction of anesthesia may mimic hypocalcemia, especially postoperatively on day 2. But if the patient calls you day 2, day 3 that he has myalgia, don't wait. Don't say, oh, it may be effect of the surgery. No. Go ahead, tell the patient, go to the pharmacy, buy calcium, swallow, then come and I see you. Don't wait for him to develop the tetany or the Schwarzenstein or the spasm of the fingers or the laryngeal spasm, which is, especially when they get laryngeal spasm, it is quite severe. It is an emergency. Don't wait. Call them immediately, because that is hypocalcemia. And you know how to treat hypocalcemia: IV calcium gluconate. You run the 10 mils, dilute it over 10 minutes, give a bolus. Then after that, give an infusion to run slowly for about 2 hours. Then usually there's a dramatic change and you discharge the patients on calcium tablets. Then you slowly taper it off until the other parathyroids take over. So you should always look for such cases. And normally after parathyroid surgeries, what you fear most is what is the word, just the hungry bone syndrome, which I don't see mentioned. Hungry bone syndrome, where there is severe hypocalcemia. You will have to give this patient calcium gluconate intermittently until the symptoms go down. Actually, they are very severe presentations of hypocalcemia with severe tetany, groaning, moaning, and the patient is really in pain. You must rush and give calcium gluconate. And always, if you stabilize the patient, then you can continue with calcium tablets until the other parathyroid glands take over. So in the management, you may have to give, you can, in the surgery, one we did not mention is you may have a minimal approach. If the sonographer tells you that there's only one parathyroid involved, commonly we see the inferior parathyroids. I don't know why, but recently I got a superior parathyroid, right superior parathyroid, which was grossly enlarged, and everybody was thinking this was a thyroid nodule, until when the patient had multiple fractures and thinning of the bone. Then they said, by the time she came to me, I just said, no, this is a parathyroid adenoma, we should remove it. And when we removed, of course, her symptoms went down, but the fractures were already there, and it takes time for those fractures to heal. Right now, she is still on a wheelchair. I don't know how long it will take before she gets up finally to walk. It will be a long time because she has multiple fractures of the pelvis, the femur, the humerus, name it. Almost all the bones are fractured. So she's on a wheelchair. Another thing that, yes, I was talking about the surgery. If it is only one adenoma, you may have to do minimal access. You go make a small incision, maybe 2 or 3 centimeters over there, and you remove the parathyroid. Or if there are many, if there are more than one gland involved, especially in hyperplasia, where in hyperplasia all the 4 glands are involved, you remove 3 out of the 4 glands and leave 1 gland. Of course, the dangers of hypocalcemia are there after, but you control it. So the remaining gland, you may decide to implant it in the forearm muscle or on the sternocleidomastoid. But in hyperparathyroidism, it is better to plant it in the forearm muscle because the hyperparathyroidism that is in the brachioradialis, the hyperparathyroidism may recur. So if it recurs just under local anesthesia, you can go and remove that parathyroid, chop it into smaller pieces, and return only a small piece. Usually they get blood supply and function again. So you can easily do it. Meanwhile, if you had planted it in the sternocleidomastoid, then you have to open the neck again to reach the sternocleidomastoid. You can't do minimal access for that, or under local anesthesia, you may not be able to trace it properly. So that is for if the 4 glands are involved, you can do that. You make a big incision for parathyroidectomy. Sometimes the gland is embedded within the thyroid gland, and you may be forced to remove 1 lobe of the thyroid gland to cure the hyperparathyroidism. So the approach to surgery of the parathyroid depends on the presentation. Whether you are dealing with a single adenoma, multiple adenomas, or you are dealing with hyperparathyroidism, and then you must decide how you are going to approach this. Then usually before surgery, you must do PTH assay. You must know the PTH before surgery for hyperparathyroidism. Take the patient to surgery. Then if you remove the offending gland, that is the adenoma you have isolated, you do another PTH assay before you close the wound. So the half-life of PTH is about 20 minutes. So as you remove, you wait until the lab tells you the second level. Say if the initial level is 800 and then it falls to 400, you can close because you need a fall of about 50% from the initial to after removal of the adenoma. Then you close the wound. If it is still high, don't close, look for another adenoma, or you have removed a thyroid nodule instead of a parathyroid adenoma. So you don't close until you wait for the lab to announce the level of the parathyroid hormone. That is very important, especially in our case, even in good centers. That is the assay they use. You don't use calcium, you use parathyroid hormone during the surgery of parathyroid gland. So you must alert your lab before you take the patient in. You just don't take the patient and do your surgery and come out. The lab must be alert, and it is best to deal with 1 lab tech so that he knows what he's supposed to do and comes back to you and tells you that the levels have gone down. The complications are similar to the ones in parathyroidectomy, because if you remember the anatomy he showed you, the recurrent laryngeal nerve just passes near the inferior glands. So you can easily injure, whether you are doing minimal access or you are doing open access. You can injure inferiorly the recurrent laryngeal nerve and superiorly the external branch of the superior laryngeal nerve. So be careful, look and avoid injury to the nerve. Hematomas and so forth are other complications you may get in the surgery of the parathyroid gland. So careful follow-up is very, very important, especially gaining the bone mineral density, supplementing the patient's vitamin D, especially if you do vitamin assay and you find that they have low vitamin D, supplement it. And ask the patient to be ambulant. Try. For this patient who is on the wheelchair, I have engaged the physiotherapist to make sure she moves the bones so that you have calcium being mobilized out and circulated. Then I've told them, take her in the sun and make all movements possible so that the muscles move, and then supplement the calcium as much as possible. So parathyroid disease is a very interesting disease. So always be on the lookout. Are there any questions? Any questions?
Yes, I have a question.
Yes, please.
Yes, sorry. My question is, first,
Yes,
I would
I have
like
a
to
question.
thank you, Dr.FAULAL. Secondly, I would like to ask a question about, in case there is accidental parathyroid removal, we can manage this problem by doing an implantation of parathyroid on the arm. So, shall we say that this implanted parathyroid will produce a considerable amount of parathyroid hormone after implantation?
Okay, is that the question? Whether this parathyroid gland you have removed will produce enough parathyroid hormone?
Yes, after implantation of the arm.
Okay, now get me clearly. We don't commonly do it in the arm except in hyperplasia. Hyperplasia. That is when you put it in the forearm, because normally if it is hyperplasia of the parathyroid, it will involve all the 4 parathyroid glands. So you have to remove 3 out of the 4 parathyroid glands. Then the 4th one, you remove it and put it in the forearm. Now, I must now put it together with, in case you accidentally, okay, before you put it in the forearm, you need to put it, ideally you should put it in the ice box, it becomes firm, then you chop it into small pieces, open a pouch in the brachioradialis and implant it there. It will always get neovascularization and produce parathyroid hormone. That is why, should the patient develop hyperparathyroidism, you go back under local anesthesia. You can locate where this parathyroid gland, under local anesthesia, go, remove that gland, chop off about half or even leave a quarter and put back in the brachioradialis. Now, that reminds me of normal surgery in a thyroid gland. Sometimes accidentally you dislodge the parathyroid gland, or you have done a thyroidectomy and you see the thyroid gland behind, I mean the parathyroid gland behind your thyroid gland. So don't discard parathyroid. Pick it, put it in saline, or put it over an ice cube. It becomes turgid. Cut it into small pieces with their surgical blade. Some people crush it with a small instrument, and then open a pouch in the sternocleidomastoid, because here you are dealing with a normal gland. You are not dealing with a hyperplastic gland. This is a normal parathyroid gland. Open a pouch into the sternocleidomastoid, put your parathyroid gland there. It will develop, get neovascularization, and produce the parathyroid hormone and help the patient from developing hypothyroidism. So do that for all the thyroidectomies that you do. Look for the parathyroid gland, because if this patient presents with hypoparathyroidism, you will sweat to treat that hypoparathyroidism. It is so dramatic that you don't like to be faced by such a patient. Okay, so always look for the parathyroid, and should it be dislodged, try to implant it. Have I answered your question?
Yes, doctor. Thank you very much.
Okay. Any other?
Thank you, Prof. I have only one question. So, Prof, the parathyroid is behind to the thyroid gland. So, if it is the swelling of the parathyroid gland, is it possible to miss because of it is behind the parathyroid and we will not find the animals?
I don't think I've got you clearly.
I say, if the parathyroid, there is swelling of the parathyroid gland, or there is a tumor in the parathyroid gland that is behind to the thyroid gland. So, is it possible to miss or to not get the parathyroid swelling because of its behind or the posterior to the thyroid gland?
Normally you should have done your ultrasound, and a good sonographer will tell you whether it is intrathyroid or in its normal position behind the thyroid gland. Usually the inferior one is behind, and then the superior one is usually as near the branches of the superior thyroid artery and vein. So as you are climbing your superior thyroid artery and vein, you will see clearly you'll see your parathyroid so clearly that, as I said earlier on, if you are if you find that it is intrathyroid, you may have to do a lobectomy in order to remove that adenoma. Okay? I don't know if I get your answer correctly, but still, your question reminds me of one thing. When you are removing a parathyroid adenoma, make sure you don't break the capsule. Remove it whole. Some of them undergo cystic degeneration, and they may have a very fragile wall, and so you may injure it. And if you spill the parathyroid tissue into that wound, you'll get what we call a matosis. So you will get a lot of parathyroid cells in your wound. So make sure you irrigate the wound thoroughly, and you can even use hypertonic saline so that you kill off the parathyroid cells. Otherwise, you're going to get features of hyperparathyroidism because you've scattered parathyroid cells into your thyroid, into the bed, the surgical bed. So try your best not to break the capsule of the parathyroid adenoma and avoid spillage of the parathyroid cells into the gland. So I don't know whether I got your question very well, and if or
Yes.
indirectly I have answered it.
Yes, I have got. Thank you, Prof.
I have one question.
Yes, please.
In case of hyperplasia, we removed those three glands. They remain also bring the features of hyperthyroidism. So we in up to the liver, we must decide to remove also the last one. Is it possible to get a thyroid from a donor and implant it, for example, in the brachial patch, something like that?
Parathyroid donations have not yet been tried. Normally, you try to use the patient's own gland as much as possible. Yes. And the reason why we remove the parathyroid from and then plant it in the brachioradialis is the fact that after doing such extensive surgery, you are going to get scarring in the neck. A second surgery or a third surgery will be so difficult. Even the anatomy will be so distorted. You may not be able to locate that parathyroid, the fourth parathyroid. That is why in the same sitting, you remove that fourth parathyroid and put it in the brachioradialis. So that should the patient present with features of hyperparathyroidism, again, which you have intended to treat by removing the three parathyroids, you go to the brachioradialis and remove. Because that is in hyperparathyroidism. Now, for hypoparathyroidism, that is where you are thinking of getting a transplant from another person. It has never been tried. In any case, in that situation, what you are lacking is calcium. The patient may have to take calcium for the rest of his life, supplement his calcium. But normally the body may adapt by working within the lower limit of calcium levels. It may adapt to a hypocalcemia of sorts, and the patient lives normally. You do his calcium level, you find it is always low, but he's living his life, is normal. But you don't allow it to go so much below the lower limit. Try to keep it around the lower limit if you don't want to gain excess calcium in the patient's body. I know there are certain parathormone supplements that have been tried, but they're still too expensive for it still has to be swallowed. And then it is too expensive for our population, and it is not available in our environment. So we still remain with our calcium supplements for patients who may have hypocalcemia. Okay.
Thank you, Professor.
Any other question? If there are no questions, I wish you the best. It is almost going to 9. I thank everybody who has joined this meeting, and I wish you a good night. Your group leader will discuss with me, and we'll see when next to have another talk and another talk. Good night.
Thank you, Professor.